Hello. It feels like I'm going to lose this thing on my ear, so. But hello. Well, the final talk before the coffee break. I'm going to present some results from a study about physicians' work environment. And it's in the same theme as the others, but trying to find out how it is to work in a specific context as a physician. And this is I've done with co-workers, Eva Beirut and Hans Hasselblad at Örebro University. And when we talk about context, when looking at physicians, it's interesting to know how it is to work within new public management. And more specifically, we looked at a system named diagnose-related groups, as Eleanor was into. There you are. And what is it? I never heard of it before. It's more internal, I understand, for people working within medical areas. But it's a classification system, a standardized classification system for clinical work at hospitals. But since 2010, it's also used within health centers, vårdcentraler, and psychiatry. And the thing with it, well, it sounds quite logical. We need to define what different diagnosis is for some is. And but what the system is used for is to divide patients into different groups based on, I don't know about the English here, it's about the main or the first diagnosis, and then you have secondary or minor diagnosis. It's B-diagnos in Swedish. Someone can probably help me with the words here in this room. But you have a classification system and which are given points, DRG points. And those points are related to money. So it's a way of making it more to compare and to follow up how it's going, if it's a productive healthcare or not. And most of the counties in Sweden are using this for follow-up. So it's a common way to follow up, also for budgeting and planning of healthcare. But it's also used as a system when it's the resource allocation to the different clinics are going all through this system, which means that you need to be really good at defining diagnosis in order to get money for your operations. And it's about half of the counties in Sweden are using it as both follow-up but also as a way of a base for resource allocation. And over time it includes more and more parts of the healthcare, and also it becomes more and more detailed classifications. The research so far has focused on this as a technical system. It's not been questioned so much how it is to work within it as a physician. And it's not surprisingly, it is shown that as it is this classification system that counts, then you report more diagnosis. And it's also shown that in some cases, it's manipulated because you rather report diagnosis that get you more money, because of course you want to have good economic in your workplace. But what we wanted to see is how is it to work within this type of system as a physician? How is it related to work environment? And to get an answer on that, we made a survey that was carried out in 2010 to 3,000 physicians, and they were randomly chosen from the member registration in the Swedish Medical Association, Läkarförbundet. About half of them answered. And for this study, it's 879 physicians included, about half, a little bit more men than women. And it was only focused on physicians at hospitals, since the system has been used much longer there than in the other places. And as you can see, the regions or counties that had a low degree of this DRG, which was called like DRG, they only use it for follow-up, only the first way to use it. It's about 11, and the others who used it also for resource allocation, and it was 10. And the information of how do you know what kind of system they are using in all the counties in Sweden? Well, the information comes from Socialstyrelsen and not from the physicians themselves. So, as we have clustered data, we have about 879 physicians clustered within different counties that have either a high degree of or a low degree of DRG. We used the multi-level analysis. And at first we wanted to see if there was a risk or not to be working in the counties with a high degree of DRG or not. And then of course we wanted to see if there are other things that can result in differences in work environment, of course, among physicians in the whole country. So we tried to control for some of the factors, such as sex, age, and whether you had responsibility for operations, personnel, or management. And also tried to control for size of the county and type of hospital. So we could focus more on high or low degree of DRG. What about work environment? Well, we tried different types, most psychosocial and organizational factors. We looked at the job demands, decision authority, skill utilization, whether you had social support from manager, whether it was organizational clarity for your work, it was defined in some way what is my responsible area and so on. If there was a possibility for the physicians as a profession to have an impact on decisions concerning the operations as such, or if they were stand aside. If there was a conflict between personal and organizational values. If they had dilemmas in care. If the system is somehow, gave problems in how to provide care in the care situation. And whether they had obstacles. Obstacles means when you need to do something else than what you're supposed to do. It could be interrupted of others, technical problems with machines and so on. So it was different types of psychosocial and organizational factors. And the significant results showed that DRG had that physicians working in counties with a high degree of DRG, they had less of the good working conditions and more of the bad, compared to physicians working in a county with a low degree of DRG.
Was a DRG, if it's high, is it good or bad?
If you look at the first, now I'm pointing on mine. Well, it's good if it's if DRG improves decision authority, skill utilization, support by manager, and influence of the profession, then it's positive. But here it goes the other way around, so it's a negative effect to work in these counties compared with the others when we're looking at those psychosocial factors. But instead we can see it down on the last rows that physicians working at counties with a high degree of DRG, they have a higher risk of having conflicting values. Their personal values are not in line with the organizations, and they also experience care dilemmas in to much higher degree than other physicians. And when we control for all those factors about who you are and where you are, that could contribute to differences in those factors, so we could see that it doesn't make any change really. When we include confounders, it's about the same results. So a short sum, it only had negative effects on physicians' work environment to work in counties with a high degree of DRG. And actually it has been a huge protest from physicians about DRG, that they wanted to have another type of system for governance in the healthcare, but I don't know where that ended. I haven't heard the end of that story. It started up some, I don't know. No, I forgot it. I'm sorry, but it has been protests, but I don't know where it's ended or where it's landed today, because this was 2010. The data was collected, and since then I don't know how the development has gone. If it's all the counties are going up to more DRG or not, and if they are, if it's going down, then what is coming instead. The Swedish government is talking about going beyond new public management as a strategy, but we will see where that ends. But when results like this, it sounds like a good idea. And it also is in line with other studies showing that it's a conflict between professional groups and new public management. Yeah, I stay there. Thank you.